Hello, hi, good evening, everyone. So last time also Dr. Mayur Khairnar have already given the presentation. So those who don't know about Dr. Mayur Khairnar, so let me introduce. He has completed his BDS and MDS in periodontology and implantology. Apart from this, he is also a fellow and diplomat of ICOI and currently pursuing PhD in dental implants. And to my surprise, he has already have done the successful dental implant which is around 26,000, and he specializes in graftless and immediate loading solutions. Moreover, he has also published 12 international research papers in a very high SCI journals, and yes, he is also having multiple patents to his credit. He has also conducted several clinical workshops and trained clinicians globally. So Dr. Khairnar is a pioneer in advanced techniques, including the engagement of implants. If you talk about the pterygoid or nasal floor or lingual, cortical, etc. The Quickdent company is designed especially to overcome the complications and offer graftless solution with a lifetime warranty and durability. So now let's talk about the topic of today's session, that is preferred by surgeons bicortical TPR two-piece rough surface implants in full arch implants restoration. So in this webinar, you will be learning about the clinical advantages, biomechanics, and surgical protocols for two-piece bicortical implants, emphasizing their application in full arch implant restorations. You will also gain insight into achieving predictable outcomes in graftless solutions for resorbed bone cases, transforming the treatment experience for both patients and clinicians. So before starting this session, you guys might be knowing that if you have joined and you have any queries or questions, then you may put your questions in Q&A box, and at the end of the session we will answer to your question. And now it's time to start the webinar. So yes, all over to you, Dr. Mayur. You may start your presentation.
Thank you, Dr. Shreya, for the wonderful introduction. And I'm very sure all the doctors who have joined for the webinars are very excited for this today's webinar, because this is something unique and something different. So yes, today we are going to talk on bicortical two-piece rough surface implant. Okay, because bicortical implants, till now what you used to hear is all about all smooth surface implants, and they used to be single piece. But today we are going to talk on more rationalized implant design, which is more predictable and also give us retrieval options. So today we're going to talk on this. So more importantly, I want to understand whenever you guys hear about dental implants, right? So how many of you think when you hear something called dental implant, this particular picture comes in your mind? Am I right? So this is very often whenever I ask anyone in the lecture or in the webinar or maybe in the conferences, everybody says, yeah, absolutely, this is the picture which comes in their mind, because we are conditioned like that. So what are we conditioned like? For example, if this picture shows that dental implants are meant only for single tooth restoration, and that has been picturized in our mind. But is this the real indications of the dental implant? Absolutely no. This is one of the indication of dental implant, but yes, the patient have an options to get the fixed teeth with the help of a dental bridge as well. Am I right? So what are the real indications of the dental implants where patient have no options to get fixed teeth other than dental implants? And these are such cases, where absolutely there is no abutment or a tooth available posteriorly, or a posterior abutments are available. Their only options left out is dental implants. Okay, but usually, because there is a common saying, because these areas are always deficient in bone, so such cases are very difficult to treat. Okay, plus, these patients, wherever there is a bone loss, there's a common saying that such patients also have no time. Why? Because these patients are highly affording, though they are very highly affording, they can afford the treatment, but they don't have time. Plus they have a bone deficiency. Why? Because it's nothing magic, because it has been said everywhere in the world that patients who have bone don't have money, and patients who have no bone but have abundant of money to spend on the treatment, but they don't have the bone, right? This is true. This is absolutely true. But why there is no magic in this. The busy people always earn more, and they don't have time to invest their time in dental treatment. For them, this is the least priority. So they come to you when the situation is worst. And when you are not in a situation to solve this problem, they will search on Google and go to someone who can solve that, because they want to save their time. So if we change our focus and if we upgrade our skills, we will be in a situation to solve such cases also with immediate loading, and we can save the time of the patients, and they will be happy to give you their money, as well as they will be happy to give you blessings, because they are being solved out of their problems in just limited time period of 5 days, 7 days, and that is nothing but immediate loading. And how it would be if you even solve such cases. Now you can see, I hope everybody understand what is the CBCT. This is a section above me is nothing but the anterior CBCT section, where it is showing a very thin bone. How if it would be, okay, if you can give a graftless solution to such patient with a high success rate, okay, and improve their quality of life and give them treatment results within least possible time, how it would be? Definitely they will give you blessing, definitely they will give you a good amount of referral, and of course they will be happy to pay you, which other patients are not doing. So definitely today such kind of treatments are also possible. Okay, now if you take, so we dentists been doing immediate loading since maybe around 20 years, not more than that, or maybe 15 to 20 years maximum. If you see orthopedicians, they have been doing immediate loading since long. They are making their patients, especially hip joint replacement and knee joint replacement patient, they don't say you wait for 2 months, or 3 months and then you start walking. No, they make their patient walk with the physiotherapy, with the assisted walking in around 3 to 5 days. So if the patient who is undergoing hip joint replacement can walk, then why can't we make our patient achieve in 3 to 5 days with the help of dental implants? The bone is the same, no? Bone is the same. Maybe embryologically it is different, but the histologically and physiologically the bone is the same in the hip or in the jawbone. It is not the cow bone here or a sheep bone in the hip. It is the same. It's a human bone, right? The physiology is the same. Everything is the same. So it is possible. Practically it is possible. And whatever concept they are using in their day-to-day practice is something similar we are going to employ for immediate loading in dental. So if you see, this is the fracture humerus. These all implants are bicortical fixated. Okay, you can see the on the left side you can see the section. So this X-rays, all the implants are bicortically fixated. None of them are parallel to each other. Few of them are definitely, but none of them, all of them are parallel. Then if you see, they are splintered to each other with the help of a rigid metal plate. Okay, it is rigid. It is not a non-rigid plate, and the fracture has been reduced, and then patient is being asked to do the physiotherapy in 3 to 5 days. Okay, same way what we are doing, what we are doing is the same thing. We are doing the same thing exactly. We are also using bicortical fixation. That means we are engaging two cortical bones. Okay, we are placing implant which are non-parallel to implant. So everybody tells it tilt, but it is nothing but a non-parallel implants. Non-parallelity gives you macro retention to the system. Okay, and then what you have is the metal prosthesis, a rigid metal plate. Okay, it is similar to the metal plate of fracture. So this is metal prosthesis. Okay, and then you load the implants once you get the high torque, because you are engaging the implant in high mineralized bone, that is bicortical fixation. You get a fantastic torque, and you are in a situation to load the patient. So only one mistake which dentist has been doing since last many years is they are not using a rigid splints. Okay, they are using acrylic teeth. So what happens eventually in certain times, if they're lucky enough, then it's okay. But if they're not lucky, the acrylic fractures and the whole system goes waste. So it is always a recommendation. Whenever immediate loading is recommended, it is good to use a thick rigid metal plate, okay, or a thick rigid splints. So it could be your acrylic, it could be your metal acrylic, it could be porcelain fused to metal or prosthesis, or it could be a metal bar. Okay, something like this. So now if you see this X-ray, you know what is this X-ray? This is an X-ray on which Branham coined osseointegration, term osseointegration. Now if you see this, although he coined the term osseointegration, but if he missed one very important point, and what was that? He was not able to retrieve this optic chamber after a certain period of time. Why? Because and then it coined it osseointegration. But what most important thing he missed was all these implants were bicortically fixated in a rabbit tibia and fibula. Okay, so that's why he was not able to fix. He was not able to retrieve it, and that's where he coined the term osseointegration. So had Brannemark have understood that one factor would be a bicortical fixation, today implantology would have changed from that time itself, right? So on basis of this concept, this is nothing new. Many single piece implants were being followed in our country since last 10 years. Okay, and they are working to some extent good in some cases. Okay, for example, this is one of my case where we have done in 2000, probably 2016 or 2014. Now it is still working well. Pencil thin mandible, even the both cases are mine. The only problem with this is there is a retrievability is a major issue. We don't have a retrievable option. For example, this was also one of the case which we did in 2017. If you see a circle on the lower left quadrant, so there the problem happened and we had to remove this bridge. So it was a big headache for us to retrieve this prosthesis, and then we replace ultimately that with a screw return option in the lower jaw. So it was not very easy. So coming to that, what is a more better option is, if we get a bicortical fixation along with a retrievability option, that will be the fantastic game. Okay, so for example, in this case, if you see, bicortical fixation can happen either through the immediate loading can happen either through two methods. One is by bicortical or multicortical engagement, or by corticalization of the cancellous bone. The corticalization of cancellous bone is nothing but doing under osteotomy and placing a wider implant, so you get a high torque. Okay, same way, when the cancellous bone is soft enough, it is not possible to get such torque. So that's where we go and engage the second cortical bone and we can get a much better torque. Okay, so that's how we usually do it. Okay, now there is a special design which is called bicortical two-piece implant. Okay, two-piece rough surface implant. That is why it's called cortical TPR. TPR is none of the name of the scientist, but it is a two-piece rough surface. This is one of my patent, but still this works wonderful today. Many of the doctors are using it. It has a crestal area which is polished. Okay, and the crestal areas also has a micro threads. Okay, now these crestal areas are polished because it is used in pterygoid areas where the bone is very soft and very prone to resorption, crestal area. It is also used flapless cases many times. So many times what happens, some of the part of the implant may get exposed. That's why to avoid the peri-implantitis, again this crestal polished area works fantastic. It is also used in a periodontally compromised dentition, so it works fantastic. Okay, so that's why it is having a crestal polished area. It can work as a one-stage implant also, and also it can be work as a two-stage implant also. Okay, so then the implant have a compressive threads because it can condenses the cancellous bone. It has a self-tapping threads, so it is having a groove inside it. So it just condenses the bone and it cuts the bone by its own, and with a minimum possible drilling, that is it can go and engage the bone. So that's why the tip is very narrow and polished. So this tip can go and engage into the second cortical, and it is equivalent to the length of the diameter of the drill. So it works fantastic for a narrow ridge cases. This I think I showed you in the last webinar also. So where the narrow ridge is there, and if you do expansion or ridge split, sometimes the crestal bone can expose. But here the chances of exposure of the central bone is very minimum if you are having a soft bone. Definitely not a problem. Dense bone, I recommend doing more drilling, and sometimes it can work. For example, if you see the osteotomies, so I recommend for a D3 and D4 type of bone, one single drill and you place the implants. Or when in D1, D2 bone, you need to do some additional osteotomies with pilot drill, also following the step drills, and then it is possible to place the implants. So you can see in very thin bone ridge also, TPR of 3.5 diameter was placed, and then we removed it, and still the bone is great. And there has been a minor expansion of the bone, and it went fantastically. It got a very good torque because from the apex we got a bicortical fixation, and the crestal area the bone got expanded because it works like an expander screw. We never use anything like a sub drills which are which condenses the bone. There are many drills in the market which condenses the bone. Okay, we don't use this because after pilot drill we directly place the implant in soft bone, so we don't have to depend on any extra armamentarium. Our implant itself is a implant which condenses or which densify the bone. Okay, now this is the cortical TPR designs. As I've already mentioned you, the rough part which is there is the RBM surface, so we don't have a concerns with osseointegrations. It has a self-penetrating tip, so the minimum osteotomy is also more than fine. We have two diameters in this, that is 3.5 and 4.2, and with the length from 10 millimeter till 25 millimeter. Now why 10 millimeter is the shortest length? Because we place the implant at a tilt. So when the vertical height is 6 millimeters, we can still place the 10 millimeter implants in tilt, because there will be tilt in two directions. One is the buccolingual direction and one is the mesiodistal direction. So we can easily cover up 4 millimeter of vertical length. So 10 millimeter is more than enough for 6 millimeter of length of height. So that's why we have a most the shortest length is 10 millimeter and the longest length is 25 when the pterygoids are located very superiorly. You will come to know, I'll give you a brief idea about that as well. Okay, then again, the system is very well equipped with the retrievable options, with all digital retrievable options, I would say. All multi-unit ranging from 0 degree till 60 degree, everything is available. Of course, it can be used in combination with the zygomatic implants because 52 and 60 degree are the multi-unit which is commonly used for zygomatic, but then it works fantastic with the zygomatic implants to give amazing successful results. Okay, these are certain x-rays. Now because the implant is narrower, now if you see in this x-rays, we have bypassed the impacted third molar on the palatal side, and now we have more than 1 year of follow-up of this case. So this works fantastic because the implant is narrower. Okay, and the bone is, of course, width is very narrow, so wherever the bone is good in volume we prefer 4.2 diameters, and wherever the bone is narrower in width we use 3.5 diameters. Now 3.5 diameter is the implant which is used can be used very promisingly, because there has been fatigue testing which is done on this particular implant, and it doesn't break even at a higher load of 512 Newton centimeters. Okay, now what is that 500 Newton centimeter? A tortoise is biting. Okay, what is the biting force of tortoise? Is 512 Newton centimeters. Okay, that's a force of even at that force implant doesn't break. At 97,000 cycles also, 97,000 times, if tortoise bites, then also the implant won't break that way. Okay, at that too at 30 degree. So my friends, this is absolutely safe implants. Anyone wants, we can share you the fatigue testing reports as well. So that is very important. If you're doing a tilted implant, the fatigue testing reports has to be matched, and this is certain way we do the implants. This is the digital aspects. So the whole digital library is very well equipped, and everything right from scan bodies to analogs, and everything is very well equipped with the system. We can design a screw retain prosthesis. That's the best advantage. Now what is that, why it is best advantage? For example, take this case. Okay, so someone gave an option of single piece implant, but we gave an option to him that we can give you retrievable options instead of single piece. Go for that, and he luckily went with that. And after exactly 1 year, what we found that his central incisor chipped off. This can happen because of many reasons: patient achieving not perfectly, or maybe not sufficiently good firing of the prosthesis or something like that. This can happen. This chipped off, we took out the prosthesis, we can check the healing, and we send it to the lab corrected the process, and next after 2 days we just delivered the process to the patient. Okay, now that's the advantage of a retrievable. Now let's go to the surgical aspect. If we are doing a bicortical, then when and where? Okay, so these are the target zone of implant placement. So in premaxilla, we usually our second cortical target zone is the is like a nasal floor, antenasal spine. Then we have a canine buttress, zygomatic buttress, and pterygoid buttress. In mandible, whole bone is completely densified, so we don't have to worry more about getting a second cortical engagement in the anterior mandible. That means in intermental foramen. But sometimes the bone is very less dense, or I would say D4, then we sometimes engage the base of the mandible. And in the posterior, either we go straight like any conventional implant, or we can engage the buccal cortical or a lingual cortical engagement. okay, lingual cortical bone, so that we can get a bicortical fixation. For example, this case, okay. So here everything is in a bicortical, and you can see this. So I'll be talking on specifically such type of design of cases. So let's first explore premaxilla. You can see the bone is very soft. Here the chances of getting a good torque is very minimum because cancellous bone is very soft. Okay, let's take this. Here our target zone is to engage the nasal floor. Now you see how we do it. This is a very thin bone case. You can see almost the concavity is there. So what we decided, we did the crestal ridge split till maybe around height of 10-12 millimeters. We just reduced those concavity, and we straight away placed one drill, and we placed this particular one drill was used to go and engage the second cortical bone, and then straight away place the implants. After placing the implant, this is the implant is almost into nasal spine. Okay, this is the healing of the patients after certainly prescribed healing period, and this is the abutment, and this is the final process of the patient. You can see how much of the bone was expanded, okay, with just one drill. Of course, so we used certainly ridge splits, and we placed the implant. So we were not dependent on the crestal bone for the primary stability. Our primary stability was from the apical bone, that is the basal bone. Okay, so that's how we could get a fantastic result in this case without any massive grafting. We didn't do any kind of grafting. No other sites were used for grafting. Okay, I'll show you. But the common problem with such cases is here the access hole is coming on the labial side. Now, how many of you know if the access hole in the anterior is coming on the labial side, we cannot give screw retain processes? Am I right? If you are with me, you can say yes, we cannot give screw retain process. Yes. So it is impossible to give screw retain. So on the image above me, can we give a screw retain processes? No, because access hole is coming on the labial side. Let me show you in such cases how we can give still screw retain processes. That is a game changer. Am I right? That will be a game changer. Fantastic. So let's take this case. We extracted this fractured tooth, and we did the drilling, perforating the second cortical bone and placing the implants. This is done. You can see the osteotomy. This is just one drill. The drill is around 2.2 millimeters in diameter. The tip of the implant is also 2.2 diameters. Okay. Now, when the bone is soft enough, sometime then we are placing the implant. Sometimes we may misdirect the implant. See what you can see on the animation above. That's why the direction of the insertion and the osteotomy should be very same. So I'm properly engaging the implant into the right osteotomy. Sometimes what happens, in order to make the implants access hole coming on the palatal side, we tend to place implant straight, and we come out of the labial side in the apical area, and that's where it creates an infection and the problem. Am I right? So don't worry about that. Don't do that. Rather go with the anatomy. Once you place the implants, okay, this is the prosthesis of the patient. This is the abutment and the access hole of the patient. We designed immediate prosthesis to the patient, and the access hole is coming on the labial side. Now this is the immediate temporization. Clear? Now it is very clear that if you want to give a screw retain process to the patient, it will be on the labial side. It will be on the incisal 1/3 rather. Clear? This is a transitional processes. It's ready. Transitional process given to the patient. After healing period, we will take the scan, digital scan, and this is what it is. So we are left out with no option other than giving cement retain. But I don't want to give cement retain because cement retain can cause residual cement into the periodontium over there and around the peri-implanted, and can create peri-implantitis in future. So I want to give still now something called screw retain. Now, what is another option? There's something called angle channel tie base. Now this tie base is used over here instead of the standard abutments. Okay, this allows you to correct an angle of around 15 to 20 degree. Okay, not 25-30 degree. So I can correct the angle. Now because this tie base is used, I can correct the angles, and see same case. I'm correct the angle, and I can use the same thing into the lab. Library, and I can change the access hole from the straight on the labial side to the palatal side. So I'm changing the angle, access hole. Clear? And now I'm designing the prosthesis to the patient. So my access hole is now changed to the palatal side. It needs a special key to screw this particular, and it has a special screws and special keys to tighten the prosthesis, and then you can give a cement retained, instead of cement retained you can give a screw retained prosthesis to the patient. So that's the advantage of the angle channel tie base with the particularly Quickdent implant. Similarly, this can be used for 2 implant cases also. See here, all the way anteriorly the accessory is coming on the labial side, and still we could give with the help of angle channel tie base, we could give something called palatal emergence profile or palatal access holes. So that's another thing. However, let's come to premaxilla. When you have a very thin ridges, in such cases, you can place the implants from the palatal side. Okay, so certainly certain areas where it is impossible, where we use a polished single piece implants, but majority of the cases where the bone is good enough on the palatal side, we can still go ahead with the TPR like designs. Okay, so that's an advantage. So here in this case, we made a palatal placement because there is a slope on the palatal side. If you can see, there's a slope on the palatal side everywhere. So that's why we were in a situation to place the TPR implants over there, cortical TPR implants. And that's how. Now that's how we can manage the premaxilla, nasal spine and premaxilla, that is anterior nasal floor. Now in premaxilla there is also wonderful side which is called nasal buttress, okay, also called pyriform aperture. Now you can either approach the pyriform aperture at an angle or straight, either of this way. Okay, now sometime you can also approach the pyriform aperture from the premolar region, and it may be through the sinus or may not be through the sinus. It all depends on the bone. Now on the right hand side, in the first quadrant, it is transsinus nasal buttress implant, also called a transsinus pyriform implant, and here it is the normal implants. Okay, so this is the way you can do this way. For example, here in this case, you can see the lower implant on the right side is engaged into the pyriform aperture. Now this is more than 2 years old case, and this is okay, fantastically working well. This is again, sometime you can open the flap, you can do Cadwell loop, you can reflect the sinus mucosa, and then you can place the implants engaging to the pyriform aperture. Okay, this is one of the article which I have taken, but I don't prefer opening the flap. If I'm opening the flap, instead of doing this, I will prefer to go ahead with the zygomatic implant. Okay, so now we go back. We also have a pterygoid areas. So pterygoid areas is nothing but pterygomaxillary junction. That is our fusion zone. That's where we engage the bicortical implants. So this is the target area where we engage the pterygoid implants. Now pterygoid implants, either you will get a height, okay, or you can get the width. So width is like between the distance between the two plates, and thickness is the total thickness of all the 3 union of the bone. What are 3 bones? Maxillary tuberosity. We also have a palatine bone, that is a pyramidal process of palatine bone, and we have a sphenoid bone, that is a pterygoid process of the sphenoid bone. These 3 bone will unify and form a junction, and that thickness is nothing, that thickness of that particular junction is nothing but the thickness of the bone in that region, and the height and the width. That's what I'm addressing. So your more important is anatomical variations. We have to understand either you will get a good width of bone or you will get the thin width of bone. Okay, sometimes your junction is located very close to the tuberosity, that is either 1 to 5 millimeter from the crest, and sometimes in the tuberosity there in this x-rays you can find there is abundant bone in the tuberosity, but sometimes you will not get bone. It was expanded with the maxillary sinus. Okay, so that's another variations. Sometimes the junction is located superiorly, 5 to 10 millimeter above the junction, above the 5 to 10 millimeter above, with respect to the crest of the tuberosity. So the junction is located superiorly. Sometimes the junction is located still more superiorly, like 10 millimeters. So the same angle is not applicable for all types of junction. So if we place a you can see the schematic implant over there. If I place the implant in that particular direction, I will come out of the distal wall of the maxillary sinus, or I would say distal wall of the maxilla, and I will not get good torque, but my real junction is more superiorly. So angulation will change depending upon the location of the junction. Okay, so for example, this case, it is located way superiorly, so my implant placement is more straighter, I would say, not too much inclined. Okay, so this is absolutely wrong, the lower one. The upper one is more correct because it is location is more superior, right? A lot of variations are there. You can also see the pterygoid placement in 4 steps. What is the first step is Usually we have a pterygoid osteotomes, which is like a knife or a sharp osteotomes. It just traverses your soft cancellous bone because your tuberosity has a very soft bone. Once you traverse the cancellous bone, you will get the resistance. Either you will drill against the resistance or you will tap against the resistance like this. Okay, we use either the mallet or you can use the elevators also sometimes. And then after that you perforate it and you measure what is the length. Now with the soft tissue, the length is approximately 23 millimeters. So I'll reduce the thickness of the soft tissue and I'll use the length that is 20 millimeters. Okay, so I'll place the implant in that direction. If the width is narrow, I'll use a 3.5 diameter implant. If the width is good enough, I'll place 4.2 diameter implant. Okay, that's how you can place pterygoid implants in 4 steps. That's it. But you need to know more importantly anatomy and its anatomical variations. Now that's the part of the pterygoid implants with the cortical TPR implants. Okay, let's come to the mandible. There is something called intermental foramen mandible. This bone is very dense. When the bone is dense, you don't have to always place you can place any type of implant. You can place active implant, you can place passive implant, you can also place cortical TPR implant. But if you are placing TPR implant, you need to do more osteotomies, not like 1 or 2. You would need to place additional osteotomies. Okay, so not a problem. But the problem arises if you have committed immediate loading, okay, and the anterior mandible, okay, or intermental foramen is absolutely less dense, absolutely, I would say, osteoporotic. The cancellous bone is like, empty lacunae. There's nothing over there. There it is impossible to get the immediate loading unless you engage the white bone which you see in the base of the mandible. So this is called, here when we place the implant into the base of the mandible, we called it basomandibular implants. Okay, let me repeat it. It is called basomandibular implants. Okay. So for example, here we perforate the
improves immediately the
base of the
stability of
mandible
implants.
carefully, not the
Due to
lingual
the soft
implant.
nature
Okay.
of cancellous bone, again, there is a chance of implant may slip in other direction and not reach perforation and further lose stability. This can be avoided by using twist drill to expand the perforation and maintaining the direction of osteotomy. It must be noted that in anterior mandible, we never perforate lingual cortical to prevent huge risk of sublingual hematoma. Insertion in D3-D4 bone is clockwise direction and it rarely needs anti-clockwise if higher torque is achieved due to bone.
Okay, so I hope you realize this. Okay, so we are not supposed to anywhere perforate the lingual cortical bone, but yes, base of the mandible carefully, and this need to be done by an expert surgeon. If you do with a guide, nothing less than that, it will give you a proper orientation. But the most important thing is you have to place the implant in the direction of the osteotomy. Otherwise, you will lose the direction and you will keep moving against the perforation is somewhere here, and you come here and you keep moving your implant against the up bone. So if you see this particular case we did with bicortical fixation, the tip of the implant is slightly coming out of the bone. Now this tip is nothing but it is a polished tip, absolutely polished tip. So it elevates your periosteum, and after certain years we could find that such areas the bone formation happens. If you want to know that, just type evidence of bone formation in nasal floor after bicortical fixation and type my name into the Google. You will get an article on that. So that is absolutely possible. The periosteum you raise, the bone forms over there. Okay, what if now let's anterior mandible is done. What if we go on a posterior side? More posteriorly we go, more the softer bone is there. That time it is impossible to again do the loading of the implants. Okay, first problem is the height, and sometimes the width is also problem, and the cancellous bone is sometimes soft. So here the best method is to do the linguomandibular implants by engaging the lingual bone, by which you can avoid maximum time cantilevers. Okay, what is linguomandibular implants? It engages your implant into the lingual cortical bone. Now, I will never ever emphasize on engaging the lingual, any implants to the lingual cortical bone by perforating if the implant is having a rough apical edge. Okay, if the apical part is rough, for example, what you see on the right side, definitely don't do that. It's not recommended. It is the TPR is only designed in the world which is meant for engaging the lingual cortical bone successfully and safely. We have a huge data for that. It is under publication. It will be shortly available for the general use also. So here, what is our recommendation? We use our fingers to perforate it with using the fingers, we retract the soft tissues and we perforate, and then we do the sequential osteotomy and place the implant. Now when we place the implant, our thread never come out of this perforation. Okay, and you have to, after every drilling, you have to clean the irrigate it, and you're not supposed to, your any drill, you should not have any residual infection. It should not flow into the sublingual area, otherwise flare up can happen. So we don't we recommend that. So clean the drill, do it nicely, and thoroughly irrigate it, and then place the implants in the direction of the osteotomy. Okay, so you can see over here, we measure it, and then after measuring the particular length, selecting the implant, and we are placing the implant at a tilt. Now the height is almost, in this area, I don't think so it is more than maybe 7 millimeter, 8 millimeter, but we have placed almost 12 millimeter of implant easily. And see the torque, see the amount of torque in the soft bone. It is getting, I'm sure it is more than for sure 50-60 NCM. Yes, a good torque is there. So that's when we do the lingual cortical engagement on a two-dimensional X-rays. What you will see, you're touching the nerve, but our implant is lingual to the nerve. It is not over the nerve. So that, please don't see the X-rays and get confused. It is always on the lingual aspect of the nerve. Now here the standard bone is the posterior bone is the soft bone. Okay. This is lingual cortical engagement. We can also do sometime buccal cortical engagement, but occlusal point of view, from the cantilever point of view, a lingual cortical is more favorable prosthetically than a buccal cantilever. Also, lingual cortical leads your teeth into the neutral zone. Our buccal corticals, the part of the teeth or the part of the process too much on the buccal side, it can cause irritation to the cheek, and irritation, sometimes cheek bites, many more things are there. So I prefer more of a lingual cortical engagement. But sometimes it is impossible to do lingual cortical engagement. See, in this case, here we cannot do lingual because there is no bone available to engage the lingual bone. So that time we do something called buccomandibular implants. Now here the implants are placed on the buccal aspect, you can see, and implant are placed through on the side, and this is nothing but this is called true nerve bypass. For example, let's take this case. This is a case of a failed implants. We had removed everything. You can see here, this is called buccal bypass. So this is called typically a buccal bypass. You can appreciate the implant on the buccal side. Okay, so that's called buccal bypass. Okay, let me show you certain cases with a follow-up of TPR implant. Now this is a 5-year journey case of one of my patient, which we did in around, now this is 2025, maybe this is now 7 years, not 5 years. We did this case in 2018. Okay, so now this is a pre-operative image of the patient, before and after, everywhere, right and left side. This is the X-ray of the patient. Unfortunately, I have this particular X-rays, but we have a CBCT also. The bone is not great. It is soft. It's, first of all, it's a soft in the cancellous bone region. Some area have a defect also, which you can see in the section number 69, 68. Okay, and the bone is width is quite thin enough. So wherever defect was there, we avoided this area. Mandible also, the bone is not quite thick enough. Very slender bone is there. So we decided to extract and we decided to place the implant. We avoided the area where the defect was there, and that's how we planned the implant placement. We did the implant placement. For example, in the canine region, I didn't place any implant because there was a big defect over there in second quadrant. So we avoided that. The implant is being placed with bicortical fashion, and this is the multi-unit has been attached on this. So this is a framework trial that very time on day 3, and we got a screw return process to the patient. This has been delivered that time. This is the prosthesis on day 5 of the patient, properly delivered. This is a pre and post treatment clinical image, and this is the follow-up of the patient almost around 4.5 years after. Okay, so this is an X-ray of the patient 3 years after. and we also have around 4.5 to 5 years of follow-up x-ray recently. So this patient is lucky enough that she is nearby, so she comes every 6 months to us for a religiously she comes for a follow-up with us. So the bone is very stable, everything is good, fantastically it is being maintained, all is well. Okay, this is the patient before and after. She is very happy. She's saying मेरे को जादू किया है, like I am very happy. She's happy. Okay, this is a local language, but she's very happy. Okay, you can see that happiness from her, body language. Let me show you another case, a hope for a hopeless dentition. That means a severely periodontally compromised dentition. Okay, upper teeth is gone because of and lower teeth are all flunging around. Because of this particular dentition, she has lost quite good amount of bone in the maxilla, also premaxilla. Okay, now what we decided to extract all her teeth. Maxilla were anyways edentulous, so we went ahead with a flapless approach, and after like single drill we placed the implant. So because the bone was soft enough, we decided to place more number of implant in premaxilla. So we went ahead with, instead of 6, we went ahead with this 8 implant in maxilla, and 6 in the lower jaw. And this is a jig trial which we do on the day number 2, and day 3 this is a metal trial to check the passivity of the process. That's very important. One screw test should be absolutely passive. This is the process of the patient, and patient smiling on day 5. Okay, so I give PFM processes if the bone if I get a fantastic torque, and if there is a shrinkage, we retrieve the processes and we reline it either with the composites, or we reline it, or we sometimes, rarely we do something called again PFM, but we reline it with the high glaze composites in the undersurface areas, and still the patients are very happy. Now this is the follow-up of the patient after 3 years. She definitely broke few of the something in the lower mandible, but the shrinkage is minimum. Why? Because we open the flap, we reduce the flaky bone which is going to resorb very fast, and we get a stable platform for the implant placement, because of which the shrinkage of the bone is minimum, and this all becomes self-cleansable. She is maintaining it very well, and she didn't ask for any kind of relining in the lower jaw. Upper is definitely good, because I'll show you another case how we do it with the without guides. Today we also do all these cases with the guided approach. If you want to know more about how we use guided, then definitely attend my webinar on 26th of January 11 a.m. where we'll be showing you how we do a digital method and a guided method, digital guide and guided method, and analog, that is conventional method, in the webinar. So here this is a case where we locate the position with the help of a denture, and we mark those points into the patient's mouth, and according to that we place the implant, everything flapless. This is all flapless placement. You can see there is no cut, no sutures, something like this, but not all cases can be done flapless. So don't go on any advertisement like no cut, no cut, no suture, no this thing. Sometimes you have to open the flap to reduce the bone, to accommodate the prosthesis, so to make the alveolar housing for the prosthesis. So it's very important to sometimes open the flap. Not all cases are meant for flapless. So this case definitely was indicated for flapless. It was totally edentulous with a good interarch distance. We place the implants. This is the jig trial, metal trial. We found little bit active was there. It was, so we asked them to do the corrections, and this is the final process of the patient. Now this is a very lightweight of the prosthesis. These are very lightweight processes, and this is all meant with composites, and highly glazed composites are there. So this is the patient before and after. So you can see, we can do the cases which is highly periodontally compromised also, and we can also do a cases which is massively resorbed, or also we can do a cases which is sinus is expanded by placing the implants parallel to the anterior wall of the sinus. We can also do cases like this. This is a mucormycosis case. Last lecture I already showed you another mucormycosis case. He was a priest. Now this is he is again suffering from similar type of problems. Personal life is disturbed. His age is to get married, and he's unable to get the things aligned in his life. So he decided to go ahead with this particular treatment. And here, this is the before of the patient. Luckily, he was having a posteriorly one teeth over there, but we didn't use as an abutment, but use as a vertical stopper over there. And here we place the implants in the two implants in the premaxilla and two into the zygomatic area. And we designed the process in such a way the process is not too bulky, but of course it will be in the neutral zone, and we deliver a process to the patient. You can see here properly implant is engaged into the nasal floor and anterior nasal spine, and of course the zygomatic arch. Now the implant are placed, zygoma is crisscross because there is no bone, there is too much of bone on the right hand side, so it doesn't allow us to place the implants in this particular proper parallel fashion, so it will be always crisscross such cases. And this is the process given to the patient. He's absolutely happy now, and luckily he got things aligned in his life. He is married now, and he's very happy. He keeps coming for the follow-up. It's more than now 2.5 years done for this case. So I'll show you an x-ray of patient with the bicortical fashion. You can see the implants, the pterygoid implant is placed very superiorly. All these implants are placed into the nasal floor. The lower implants is placed on the on a lingual side, the lingual cortical bone. Now, whenever you perforate, see the basomandibular implants where it is coming slightly out of the base of the mandible, but not the thread. Only what is allowed is this polished tip. That's why this implant is having a tip at the polish. Whereas other implants don't have the polished tips. So I don't recommend engaging such implants with a perforation into the basal bone or in the second cortical bicortical bone. That's the most important thing we should understand. The implant is having a standard 2.42 hex internal hex connection, which is compatible with many implant systems. There are also designs where implant is compatible with conical connections. We also have such kind of designs, but it is, I think, rarely few doctors are using it because there is a lot of armamentarium and lot of components are required for conical connections. Okay, so with this, I would like to conclude my presentation. You can find regularly cases with the cortical TPR implants on my Instagram channel. If you want, you can just definitely follow my channel. I would like to thank Quickdent for giving me extreme support for doing my cases, and stay tuned. That's more important. Now, what you saw was the most surgical aspect. What I'm going to speak on 26th of January, that is Sunday, on our Republic Day, after the flag hosting around 2 p.m. Am I right, Dr. Shreya? 2 p.m., not 11 a.m., right?
Yes, yes.
Yeah, okay. I was under impression it is 11 a.m. Now it is 2 p.m. So I think after flag hosting, everyone will be free enough. So you're more than you're more than welcome to join for this. But I will be talking on a digital and analog method, especially the prosthetic aspect as well as the surgical aspect to master the full mouth reconstruction, and majorly with the immediate loading cases. Okay. I would like to thank Dentist Channel Online, Dr. Shreya, Mr. Siddiqui, and Mr. Melvin for inviting me to give this webinar series of 3 webinars back to back. And I'm really grateful and I'm really thankful for the whole team for conducting this webinar. Thank you so much, Shreya. You can take now.
Okay, thank you. Thank you so much, Dr. Mayur. And yes, once again, we have the question answer session. So, yes, we have 2 questions. So, the first question is why there is resorption of soft and hard tissue after 1 to 3 years of treatment, which ultimately cause repeat of either prosthesis or soft and hard tissue augmentation. You can see in the Q&A.
Why there is a
Yeah.
resorption of soft and hard tissue after 1 to 3 years of are you talking about general, or you talking about particularly my cases? Now see, my friend, most important thing is that if you are doing a full mouth implant reconstruction and you're doing immediate loading in, in cases where there are teeth extraction is indicated. So this resorption is nothing but a bone remodeling post extraction, which is not in your hand. It may go and settle down by its own, and after certain period of time it will be stable. Okay, and that's where you will find sometimes the gap between the prosthesis and the gums. Now you have two options. Either you can keep it sanitary prosthesis, which will be easily cleansable for the patient, but you have to make sure that it is in acceptance with the patient. Sometimes if it is not in the smile zone, no problem, but if it is in the smile zone, then you have left off no option other than realigning the process or changing the process if required. You can also, in order to save cost of the patient and get more conversion, that is my marketing tactics, where we usually avoid transitional prosthesis. And so you can do that as well, or you can also do something. You can do transitional process, and after certain period of time you just change it to permanent process. That is also another. What is the next question? Why CBC doesn't give measurement for bicortical basal? Okay, so the most important thing is CBCT doesn't give measurement. Yes, because many OMDR are trained for conventional type of implant planning. So you have to talk with them and you have to mention them that what measurement you need is from the crest of the bone till the apical, that is the second cortical bone. But my friend, again, this will be misleading for you also, because they will be giving you a measurement in one particular direction. We are placing not straight implant, we are placing tilted implant. So their direction, if you rely on their measurement, you may go wrong. That's why there is something called depth probe, which is available particularly with Quickdent system. This is specifically meant to measure the length between the first cortical and second cortical after perforation, and just choose the implants from your stock and just place it. It's more than easy rather than depending on the measurement of getting a measurement from the your OMDR, or else you can train them. But then another option is go for a guided option. Tomorrow we'll be showing you guided option tomorrow. Okay, very nice cases, but this cases comes in routine, not comes in this type of cases are very rare. So how to convince this type of patients? Okay, so well, such, if you see, I have shown you the cases which were the common also, like anterior cases. It can also be used for a segmental. The bicortical implant can also be used for the segmental, but bicortical I don't recommend using for single molars. Okay, because single molars you need to have a robust implants, wide body implants, because the molar is wide. So go for a standard implants over there. Okay, and for such cases definitely you have to depend on standard designs. But if you get a full mouth cases where with a periodontally compromised dentition, you should go for such kind of designs. This will be helpful for you. Okay, what is your opinion? One piece compressive rough surface with MU abutment. Oh my god, this compressive implant or any implant with a attached multi-unit abutments has no fatigue testing, first of all. Okay, so according to the FDA norm, by the way, Quickdent cortical TPR implant is a FDA approved implants, and FDA approval is only available, US FDA approval is only available when you have a fatigue testing reports and you have all clinical evaluations. Okay, so these implants don't have clinical evaluations, a single piece implant with multi-unit. The problem with that is, if the screw fracture, it is impossible to take out the screw from this multi-unit. Okay, in that case, what will be the problem is, your implant is totally waste. Let's take a scenario. If this happens on any conventional implant or maybe on a TPR implant, if the screw fracture, what you can do it, maximum you can trim the multi-unit, you can retrieve the multi-unit with the which is attached to the implant, and change the multi-unit, put it in the same way, and then your problem is solved. So I believe two-piece multi-units are anytime, like standard multi-units are better than single piece multi-unit. It's a disaster. I don't believe. I don't recommend that very openly. Yeah. Thank you so much, Dr. Nikhil. Material used after implant placement, is it requires PRP bone graft in case of non-healing sockets? Not in every cases. All these grafting things you can do to get some fantastic result in aesthetic zone, because aesthetic zone needs a good soft tissue. You need to get a good bulk, but I don't think so it has any. So soft. So you can use those grafting materials for the young patients where you are placing implant in the aesthetic zone. and where you think the resorption will be happening, so there you use that. But don't use it for 78-year-old or 65-year-old, and then they are sometimes smoker, and then they facing the challenges of peri-implantitis will be, or a bone graft infection will be a big problem. What material or process most of the cases you presented? I mean, okay, see, this all depends on your interarch distance. If your interarch distance is less enough, go for a standard gold standard, that is porcelain fused to metal. If your interarch distance is more enough, you cannot give porcelain fused to metal. It will be heavy process, implant will get loaded. That time go ahead with a metal bar with the hybrid processes. Now hybrid process used to be like with the teeth setting, but today the hybrid process can be made with milling. So this could be a composite, reinforced PMMS. Many materials are there, so this is the better option. So it all depends on case to case which composite material is used for relining. This is depends on the lab, which lab. So nowadays either the GC or Ivoclar, both of them have like Adoro resin. This is a kind of a composite which is used for relining, or even for the occlusal rehab of the such cases. So this all depends on the lab. Lab will use it. You don't use the chair set composite. The lab will reline it nicely. You have to just record the amount of shrinkage. In extreme, okay, next question. Then in extreme resorb of maxilla, if you place tilted implant at least at first premolar region, then there will be no need of zygoma. Is that right, sir? No, it all depends on what amount of coverage you are getting. So if you are placing implant in first premolar, okay, tilted, and you are having a good high, the vertical length of the implant is more than 16 millimeters, then there is not a problem. But then if it is in the first premolar, at compulsory pterygoid is needed to avoid the cantilever. But if you cannot, if you are in the region of canine and the height is around 12 millimeters or something like that, then I will recommend go ahead with the zygoma compulsory. Zygoma is needed when you when you place the implant in premaxilla and the height is less than 12 millimeters or 12 millimeters. Can we join natural tooth with this type of implant? In general, whenever possible, avoid joining the implants to the natural tooth, because both biomechanics are different. But recent research shows that it can work only in certain cases where the tooth is vital and you're joining it and there is no marginal leakage to the tooth. But this should be a rescue situations, not the prime treatment option. Okay. Yeah. What is the life of the implant in periodontally compromised? The patient needs warranty. Okay. See, we are not we are not selling electronic items, so don't give warranty to any of your patients. You have to give a rather assurance that anything goes wrong, you are there to do the treatment. And that's why I always say it's like a implant is like a chakravyu. If you know to go into it, you must know how to come out of it, and you should know how to manage the complications. So give them assurance, anything goes wrong, I am there with you. Okay. So definitely go ahead. Medication prescribed, can you suggest in case of old age group? You see, medication prescribed is definitely old age group is more debilitated age group. So there we need to see certain medications, they may not be advisable. So you need to take a consent from your their physicians and give. Otherwise, general medications are antibiotics. That is, we cover gram positive, gram negative, and also we cover anaerobic bacteria, that is flagell, that is metronidazole, and amoxicillin, clavulanic acid. These are the common, and some analgesics and some medicines for the swelling you should give. These implant scan body is the same for normal abutment and MU abutment? No, implant scan body for MU is different and implant scan body for implants are different. So definitely there are two different things, as well as the implant analog, or that is for digital. MU and digital analog for implant is also different. So this is two different things. For posterior mandible, best is the lingual cortical engagement whenever it is possible. When not possible, then only go for buccal. Is it right, sir? Just clearing my thought. Okay. Yeah. So see, whenever possible, go for lingual cortical engagement. It is more favorable with respect to the occlusion concept. But when it is not possible, you can go for you evaluate whether it is really not possible. If it is really not possible, you can also go for straight placement in if the bone is allowing you. Straight placement, do delayed loading. See my friends, I'll tell you, immediate loading is a science. It's not an ego. You don't have to do immediate loading every time. More important is please improve the quality of life of your patient. That's what I always say. Okay, so if you think this is going to be problem, go for straight placement. If there is still no bone placement, then go for buckle. Buckle keep always the last resort. Okay, if my patient needs implant placement after 2 months of attack, can we play? What a kind of attack you mean to say? 2 months of, I think he can reframe the question, Mr. Dr. Kaustu. Nowadays there are many implant system and confusion for dental practitioner, patient and patient. How do Quickdent implants are different and promising apart from its FD approach? Yeah, see, most important thing is, see, here you don't have to, what is the versatility of this particular system is that it has a conventional implant designs which is very active. Okay, then it has a bicortical two-piece implant design which can be used for periodontally compromised dentition, also for immediate loading, or pterygoid also. Okay, for pterygoid placement is possible. It also has a zygomatic implants in two-piece. Now this is two-piece part. If any chance you need to do a one-piece implant for certain reason, it has definitely one-piece basal. It has a one-piece standard conventional implant which is also again bicortically fixated, and it has a one-piece zygomatic implants also. So it has, in one particular thing, we have all the options available. So that's why we prefer to go ahead with this. It is also having a guided solutions nowadays. So that's why we don't have to depend on only one particular designs. So it's more of a holistic approach rather than just specific approach. If the implant patient death suddenly in burning like pacemaker, I don't think so. This is just only the specialist who is do this cremation ceremony. You should know, will be a right person to answer this. So short implant in mandible is favorable, or buccal, or lingual? Now, it all depends. If you have a short height around 8 millimeters and you have a thick lingual cortical, I think, and if it is full arch, then definitely lingual cortical is best. But if it is only one particular tooth, then straight implant, short implants is favorable. Wait for delayed good amount of time, 2-3 months, and then give the prosthesis. But I will not recommend lingual cortical engagement for one tooth replacement, because any tilted implant for one tooth is failure. Tilted implant work only if they're splinted. Like orthopedician tilted implants, you saw fracture, because they were splinted, it is all well. If one single tilted and it's loaded, it will fail certainly. So I don't recommend that. 2 months after basic. What precautions should be taken means restriction? Yes, why not? When you're doing, suppose if you're placing this all implants and you have to do delayed loading, that means what? That's your question, Dr. Kaustubh, right? So if you're doing delayed loading, you have to just put a cover screw and close the flap. You don't put a multi-unit and send patient with a healing abutment. He will see on that and he will fail. So put a cover screw, close the flap, and then call after 2 months, then place multi-unit and do immediate loading. Okay, then you do the lead loading. Can we give hybrid prosthesis immediately in delayed loading cases? Example, lingual bypass is not possible and given straight implant. Yes, if you get a good torque by corticalization of the cancellous bone, you can definitely go ahead, no problem. Titanium implants are always preferable. All the implants are titanium only. Okay, and it is non-ferromagnetic alloy, so that's not a problem even if your patient is going into the MRI. So that's not a problem. Make sure your prosthesis is not having any iron in that. Okay, usually there is no prosthesis in the dental industry which is having iron, so not a problem. Dog, we need to buy or have to keep the bulk of the implant according to the case. Yeah. Well, if this is a good question. If you want to do ample amount of cases, you should have the bulk. You cannot call your local representative saying that get me so many implants available, and then last moment he will say no sir, I am stuck here and all this thing, and then your case gets spoiled. So it's better to buy keep a stock of 50 implants when you are around the doing one full mouth cases. Keep a stock, keep refilling it. So I also started initially with 10 implants, then 50 implant, 100 implant, 500 implant. Today we keep at least 1,000 implants in our particular practice. That's how we develop, right? So you need to have the stock. So for maxilla pterygoid, bilaterally, then one implant in the lateral region and one at least in the premolar. Exactly. So you need to place implants with in a right position. The most vital implant is the implant placed into the premolar region, okay, and an implant engaged into the premaxilla, that is nasal floor. That's the so premolar region implant is most important. If it is not there, then you have to place the zygomatic implant. Absolutely. Most common cause of implant failure is in this case, if the torque is not good, still you're loading, there's a one good cause for the failure. This is surgical. The second surgical cause would be asepsis. If you don't follow good asepsis, the implant, any implant in the world can fail. Okay, this is all surgical. The second is the prosthetic aspect, where you give take the impression, and okay, you take the impression, but your process is very active. You have failed to do the one screw test, and there a screw loosening can happen, screw failures can happen, and occlusion, of course. If you don't give a proper occlusion, that is proper occlusion scheme, that is bilateral, you should give, of course, the group function to the patient with a proper implant protected occlusion. If you give, then definitely the failure can be avoided best. And last but not least, you have to do a good amount of follow-up of the patient every year. 6 months the patient should give a good follow-up.
Okay, this is the last question that we will be taking, that how to select case, that is it implant placement or FBD or RPD, which cases implants cannot be placed. In case of resolved ridge, can we place implant?
Yes, of course, in resolved cases also we can place implants, but you should be very well equipped, or you should be very well trained enough, or you should have someone in your team who should be able to manage such cases. If you cannot manage such cases, either you refer them or you do a standard cases which you can do it, like denture. But this patient will not be very happy with the dentures if the bone is resolved. So it all depends on your knowledge and your skills, how to manage the patient. So that's why I always say these patients is a high earning, high ticket value patient, so they will definitely pay you in a good number, but then you have to upgrade your skills and you have to change your focus for that. Definitely.
Thank you so much, Dr. Mayur. They have
Thank
asked a
you.
lot of questions and you have cleared everyone's doubt. So I
Thank you.
think,
Thank you.
yeah, it is very fruitful session, I guess. So next, we will be meeting on 26th of January. And again, as he already discussed, he has already told about the topic of the presentation. So I will be telling again, the topic is decoding digital and analog method to master full mouth reconstruction with immediate loading, which is on 26th of January at 2 p.m. So don't forget to join it. And if you want to know more about the Quickdent implants, then obviously you need to attend this last webinar session of Dr. Mayur. So thank you once again. Thank you once again, everyone, for joining with us, and especially Dr. Mayur for giving such an insightful session on immediate loading implants. Yeah.
Thank you so much, Dr. Shreya. Thank you so much, whole dentist channel online team. Thank you so much.